Thank you very much, Chairperson. So basically, what I want to talk is hope for cancer patients, mainly for realistic hope and mainly for improving the quality of life. You might be surprised that when the second and first speaker talk about palliative care and also how to take care of the cancer as a whole. But for me, most of the patients who come to me as cancer patients, they're really keen to have family, or some of them at a terminal ill, especially women cancer. They ask me, doctor, can I have a kids first before I go for chemotherapy and things like that. So this is what they've been lacking in our country. So first and foremost, I just want to introduce you the term of oncofertility, because when I come back from Japan, the term of oncofertility is not well versed. So it's actually a combination of oncology as well as a fertility discipline that mix together and become oncofertility. Some people think this is dynastic discipline, but no, it started since 2007 by Teresa Woodruff in USA and become oncofertility navigation. And lastly, it evolved to become oncofertility discipline, taking over from the scientist to the clinician and implemented in the clinical practice. So in Asia, we are under the umbrella of International Society of Fertility Preservation, whereby we as an Asian country develop Asian Society of Fertility Preservation. And when I come back in 2020, I formed this Malaysian Society of Fertility Preservation and currently run as a vice president. And we enter this ASFP under the umbrella of ASFP for the oncofertility service. So when we talk about oncofertility or fertility preservation, there's a two terminology, but it's the same treatment. But fertility preservation is more on medical diseases that affect the ovary and also sperm. For example, SLE patient that requires cytotoxicity drugs to maintain the remission, or oncofertility is more for cancer patient. So in the National Cancer Survival Report in 2016, they already talked about how good is our survival in Malaysia based on our current treatment that implement in Malaysia. We have a very good cancer survival, especially in kids and also young adult. So however, although they are young adult, when you ask them, how old are you, 16 years old, are you planning to get married? They will say that nobody want to marry me because I cannot produce any children because I already been infertile. So that's why this is the thing that you need to highlight to them, because some of them, they don't want to survive because they cannot find love. Orang yang tak ada cancer pun tak dapat pasangan ni, orang yang ada cancer kan. Tak adalah lawak je. Okay? So that's why you need to know that cancer patient has heart, love that we want to share. So that's why when they know that the effect of cancer therapy is very, very bad, then they need to know that how they want to protect their fertility before cancer. That is all about oncofertility. So when they're diagnosed with cancer, first and foremost, the oncology need to highlight to them what is the effect of gonadotoxicity of chemotherapy based on their performance and their cancer stages. So you can see there is a chemotherapy agent, high risk, medium risk, or low risk that can affect this ovary. Having said that, you can also know that this radiotherapy itself also can affect the ovary, depending on how many gray of radiation that we get. So the older the patient, the lesser the gray that can actually affect the fertility. That's why I always ask their modality, is chemotherapy or radiotherapy? Some people only have a thyroid cancer, but the scattered radiation can cause harm to the gonad. So some oncology will say, tak apa, kita radiate dekat leher je, bukan pergi kat telur kau pun, macam tu. But when they come back to me, surprisingly, the sperm is gone and then the oocyte also gone. So that's why that is what we call the term of scattered radiation. In men also, you can know that men is also, although you said that woman is complex, men testis is more complex. Because in testis, there are germ cell is actively mitosis and meiosis to produce sperm every 3 months. So we don't have any bank in our testis. So that's why you can see that even Datuk K can have kids at the age of 60 years old. Because the sperm is keep producing. Compared to women, they already have the oocyte that been stored in their ovary throughout their life. So when its oocyte is gone, they are menopause. But men, there's no menopause. But when they have this radiotherapy or chemotherapy direct to the testis, their testis is gone because they cannot regenerate, because they don't have storage of the sperm. So this is very important to highlight to your oncologists. So what is our target population? I mentioned to you, I'm more on oncofertility, so we treat all sort of cancer from head to toe. But some of them only think that, oh, Faizal is gynecologist, only cervical, ovary, uterus. Other cancer no need to refer. No, I'm an onco-fertility. I treat the cancer from head to toe. So all the cancer patient, you should actually highlight about fertility and please refer to the onco-fertility service. In fertility observation, I mentioned to you all is about medical diseases or genetic diseases. This one is not much of urgency because we still have time to manipulate their medication and also give the treatment empirically depending on when they need it, okay? So how we want to talk about the option that we have now in Malaysia. So you have all sort of options that I will explain one by one. So first and foremost, oncology refused to refer to me because they love to use Lucrine or GHRH analog because for them, this is ovarian shielding. It's wrong. Okay, because in Malaysia, we always want to pick the reference which is 10 years ago or 15 years ago because that is what stated in the guideline. If you look at RCOG guideline, they said, oh, a new RCOG guideline come out in 2024. So we think that is the new guideline. But when you see the reference is 2010, 1990, you know, because all the guideline is be done by the committee who have their preference. They didn't take, oh, this group is not my thing, this group is not networking with me. So they just take what the paper they want to cite in the guideline. So that's why currently most of the Asian society or no, most of the cancer society already established that GH analog cannot become the ovarian shielding. So stop saying that by giving this GH analog, you can actually reduce the risk of gonadal toxicity. It's wrong because all the evidence has shown that the effect of gonadal protection is negligible or inconclusive in this medication. Second, when we talk about cancer patient, most of the surgeon in gynae, especially gynae oncology, said, don't worry, for radiotherapy, we can just do ovarian pligation. No need to refer to oncofertility. We will protect the ovary. If you pligate the ovary up to your brain, but you give chemotherapy, you think the chemo didn't go to the pligation area? Of course they will go. As I mentioned to you, if you radiate at the neck, you think the neck cannot get staccated radiation to pelvis? Of course. That's why if you do ovarian PEC or even you go for transposition of the ovary, you cannot run away from the gonadotoxic effect. That's why nowadays, there's no recommendation for you to go for or PEC or even ovarian transportation role because most of the cancer therapy now is concurrent chemoradiation. Baru start dah 10 minit. Okay, so what is the option that we have? So that's why as a cryobiologist, I really want you to know that the only things that can protect the fertility is the cryobiologist or cryotherapy treatment. So the man, you only have sperm freezing, but female, you have oocyte, which is egg freezing, embryo freezing if you have a partner, and last but not least, for prepubertal, you have ovarian tissue freezing. So sperm freezing is easy. You come there, you ejaculate after 5 minutes, then you can just freeze your possible offspring for 10 to 15 years. So it's easy. So if the lelaki tak nak freeze sperm, aku ketuk kepala because it's very simple. And the price is also very cheap. So you just go there, say that I want to do a sperm freezing, I'm getting chemo next week. So on the spot, you can do your sperm freezing. There's no stimulation, there's nothing that you should be worried. The only thing is when you ejaculate, we didn't see your semen volume. We see what is the sperm concentration. If we can get at least 10 million each of the vial, then it's okay. My preference, I will ask my patient to get at least 6 vials. At least 10 million every vial. So it's much more easier for us to predict at least 3 cycles of IVF by using the sperm freezing. The second thing is oocyte freezing. Currently, there's a lot of commercialization of IVF whereby they ask people, kau tak dapat, kau baru putus dengan boyfriend kau kan, pergilah freeze kau punya telur. Mana tahu nanti kau dah menopause baru jumpa pasangan kan. So there's a lot of social freezing nowadays. But when the patient come to us for oocyte freezing, for cancer patient, masa tu dia nak fikir fatwa bagi ke tidak, you know, mak aku bagi ke tidak, you know, that kind of thing. But the thing is, oocyte freezing is good for single patient who already attained menarche. So if the patient come to us, single patient, no partner, so we will ask them to go for oocyte freezing. But oocyte freezing not that easy. It's not like we take your egg then we freeze. No. Because oocyte contain a lot of water. So when we do cryopreservation, we want to dry as much as possible the water content in the cell. So there's a lot of things to be dry with oocyte. That's why the higher risk of cryo injury. So that's why you see this Goldman chart. How much is supposed to freeze if you want probability to have 1 live birth? If you are less than 35 years old, to get 100%, you need to have 40 oocyte. Satu cycle kau boleh dapat 20 usai je. You know, so 2 to 3 cycle. So that's why you need to know that the best is not usai freezing. The best is actually embryo freezing. Because embryo freezing, usai freezing, if you freeze 20, you maybe boleh guna 10 because there's a lot of cryo injury. Tapi kalau you freeze 5 embryo, you can use all 5. That's why if I see the patient, dah ada couple, belum, dah ada tunang, dah bila nak kahwin tahun depan, kahwin sekarang, so I can freeze the embryo. Okay, I write a letter, you know, during the COVID time, when the couple come to me already bertunang, tapi Tok Kadi tak buka because COVID. So, dia orang kena ambil giliran. I need to write a letter, say they are going for cancer therapy, I want usai freezing, please angkat nikah, then I can go for embryo. Because some of the patient who come to me already have very low numbers of usai. So, I cannot predict the future. But if low number of usai, if I can get at least 3 to 4 embryo, I'm much more happy. Because I know that I can give them the hope to get the children. So that's why it's very important to know the difference between embryo and also usai. The next is ovarian tissue cryopreservation. This is what I am, my service is in Malaysia, whereby I'm the only one that can do ovarian tissue freezing in Malaysia. So what we do is, we take one ovary as a whole, then we chop it into a small pieces and we freeze it. Okay, then when you want to use it, then we put it back after the cancer remission. So what we do is, we need to go for this criteria to find what is the best for the patient. So this is the criteria that we look for when the patient opted for ovarian tissue cryopreservation. So it's not that everybody is good to go for ovarian tissue, but we want this for children, because children, when you freeze the ovarian tissue, you have a lot of oocyte. But when you freeze the oocyte, most of the oocyte in children who is not yet menarche is abnormal. That's why you need to know that when you menarche, you can see the apoptosis of abnormal oocyte, then you only have like 200 or 300 oocyte throughout your reproductive life. But when you take the oocyte in the 10 years old, maybe they have millions of oocyte, but the oocyte might be not normal. That's why you're not advised to freeze oocyte in prepubertal. So this is what we go for oocyte. So when we want to put it back, the ovarian tissue, we do an operation and see how we put back the ovarian tissue here. So I have a video from Japan. So this is what we do to put back the ovarian tissue. So we just cut because we take out one ovary, the other ovary we let it be in the abdomen. So we cut it and then we make a pocket at the area of the ovary so that we induce this vascularization. You can see we want the bleeding, so that when we have that, we will put in back all the tissue that we already freeze 10 years or 20 years ago, and then we switch it back at the area of ovary, and they will actually have the good outcome. Okay, so up for now, we have more than 300 cases already that have done ovarian tissue cryopreservation worldwide. And you can see that when we put in the oocyte, ovarian tissue, how long actually the hormone will come back. Minimally 3 months. Or if not, after 6 months, there will be a very good downgrade of FSH showing the ovarian tissue is functioning. Okay, and we can see that most of the analysis show that ovarian tissue cryopreservation is very good in prepubertal, because there's a lot of pregnancy have been reported. So in Malaysia, we have done more than 30 cases since I started in 2021. But we didn't do much cases because the oncology don't want to refer to us because they didn't believe in me. Okay, so that's why when I talk to them, please refer. They didn't believe in me. If they believe, their parents didn't believe in me. So that's why the awareness need to be emphasized. So this is the paper that we published in Japan, where we have a pregnancy with our technique, which is vitrification ovarian tissue cryopreservation. So for men, the most established is firm freezing, but people asking me, if we have ovarian tissue, why we don't have a testicular tissue cryopreservation? So testicular tissue cryopreservation is much more difficult. I will tell you later. But if the patient come to me and there's no more sperm from the semen ejaculation, what we can do? We can do a TESA, PESA, or even micro-TC to search for sperm. So sperm is very important. Single sperm is very important to make sure that we can form an embryo. So micro-TC is the one that we're doing now in UKM, whereby we have a lot of cancer survivor that didn't have opportunity for sperm freezing. So when they come to me, they said, "Doctor, I really want to have offspring for my own. If Chinese or Indian, I know that you can actually opt for sperm freezing, but for Muslim, you cannot." So that's why we need to cut off the testes under the microscope and search for the sperm. So you can see that there is a potential sperm here that we can actually go for the ICSI. Alright, so this is my team when we do. We need so-called microscope from ophthalmology, so we share together with Ophthal to do this operation. So we didn't operate at the eyes, but operate in the testes. Okay. Right, so cryobiology is very, very difficult. So testicular tissue, just a bit of testicular tissue. I want to tell you how and why it's difficult. So if you see here, this is a famous monkey called Gardi the monkey. The first breakthrough of testicular tissue, pre-pubertal testicular tissue that been published, that is been born in USA under this team. And then this is the breakthrough. They say, oh, we can actually freeze pre-pubertal tissue. So when I was in Japan, the Japanese were very ambitious. I lead testicular tissue cryopreservation in Japan when I was trained there, but I just trained with my mice model. However, after kill more than 1,000 mice, I cannot get the result. And then you know that Japanese cannot accept this thing, so they bring me to Osaka and we buy a monkey. We want to try to get a monkey as similar as US. The study is still going on, so I'm very fortunate, or not unfortunate lah kot, because aku tak habiskan study ni, because I need to come back to UKM and serve and go for my PhD. So the study is still ongoing, so we will actually update. Faham, lagi 1 minit. We will update once the study have shown, but to be honest, if you ask me about testicular tissue, worldwide, there is no testicular tissue cryopreservation that is available. We are still under testicular group that is creating our head to create a proper media to ensure that this immature germ cell can propagate into a sperm, then we can use the sperm. So until now, we will try to produce a freezing, but we yet to use the freezing tissue. So all is under investigation. So integrating the oncofertility into survivorship care plan is for you to emphasize on fertility. Okay, some patient, they want to go for chemo or radio, they think it's very doom and gloom decision. But we tell them, don't worry, we will freeze your egg. Don't worry, we will freeze your sperm. Because maybe that is the one that they want to hear. Because when they go for chemo and they always say, oh, so aku tak boleh kahwin ke? So boyfriend aku macam mana? Macam tu kan. I have a life story that the patient come to me, baru kahwin, ada lung cancer, dah buang 1 lung. Bawa tong oksigen datang ke HTA, want to freeze the embryo. The HTA said, no, we didn't do oncofertility here. Then come to UKM, bring the tank oxygen. Aku pun taklah bodoh sangat. Aku cakap, siapa oncologist? Aku call. Dia kata, oh, this oncologist from HTA. So aku tanya oncologist tu, how is the survival of this patient? Dia kata, it will survive. Although buang wang lung is a chemosensitive, she's young, I really support for oncofertility service. So we did stimulation and we get 7 embryo and now she's pregnant because the HTA ONG said that he able to manage single lung mother or pregnancy with single lung. So this is integrated that we want. Some oncologists, some OBGYN don't want to support any cancer patient because they are very afraid that the cancer will regrowth or patient will jeopardize with pregnancy and so on. So that's why we need the help to integrate this in the system. So when I'm come back, I go to Magna or I go to National Cancer. Can you take me? I'm the oncofertility. They said no. Our focus is different. Magna said like this. National Cancer Society said like this. So what I did, I didn't give up. I opened my own NGO called Pertubuhan Yayasan Harapan Oncofertility. I'm the founder of Yayasan Harapan Oncofertility because I want them to know that oncofertility exists in Malaysia. As a founder and the only members, I still in the beginner of creating awareness, and I will try my best to create awareness with other cancer societies to help to integrate my NGO to help them to ni. Because some of the patient come to me want to do sperm freezing, RM200 pun tak boleh bayar. So this is why I need my NGO to support for this financial. So this is why this is why I want to do. I want to support them. Ovarian tissue preservation, 8,000. Mak bapak datang nangis-nangis tak boleh bayar. But it's good for the kids. Tapi tak ada orang nak support. I go to all the society tak nak. So aku buka sendirilah. But I'm not a social media influencer yang boleh dapat banyak dana. So far aku kumpul 14,000. I paid for 3 or 4 cases already. Sometimes aku tolak cukai aku masuk duit pendapatan sendiri untuk tolak cukai. So that's why I think that I think we should strengthen this onco-fertility to integrate in cancer survivorship in future. So this is my team in Japan. I was under Kanagawa, which is Saint Mariana, and Professor Suzuki is the president of International Society. So I'm very happy to be part of team. And then this is my team in UKM. All of us is all men. So kalau datang nak cari doktor perempuan, aku tendang. Tak ada doktor perempuan. Setakat nak free sperm, usai semua tak payah cari doktor perempuan lah, nak beranak pun cari doktor perempuan, okay? So, we all 3 of us, but I'm the only onco-fertility in UKM and in Malaysia. So, please do contact us in UKM because we are the only onco-fertility center that gazetted under KKM. So, with that, this is my last slide. If you guys are interested, especially the doctors or health alliances, kalau interested to know more about onco-fertility, fertility preservation, I am organizing an Asian society, the 5th Asian Society of Fertility Preservation. You can scan this QR code that we will actually, it's happening in Lee Meridian in August, 1st and 2nd August this year. So with that, thank you very much for listening.